Our next paper is entitled The Feasibility and Effectiveness of Laparoscopic Pylorus-Preserving Pancreatoduodenectomy, a Single Institution Experience by Dr. Zhang from the West China Hospital of Sichuan University. Please come forward.
Good morning, everyone. It's my pleasure to share our study titled The Feasibility and the Effectiveness of Laparoscopic Pylorus-Preserving Pancreatoduodenectomy. As we all know, the PD was the standard surgical approach for the treatment of the pulmonary and the pancreatic adolescents since it was first reported in 1935, and after that, the surgeons modified the surgical procedures, and in 1944, the Pylorus-Preserving Pancreatoduodenectomy developed in 1944. But in recent years, with the development of the laparoscopic skills and the update of the laparoscopic instruments and the desire of the and the benefit of the laparoscopic skills, the LPD and all the LPPPD was spread and used worldwide, but because of the complex and difficult of the surgical procedure, it was now only performed in some major medical centers worldwide. And because of these reasons, the LPPPD remains some controversial. Like some surgeons think that the Pylorus-Preserving may can't meet the radical resection of the tumors, or the Pylorus-Preserving may increase the incidence of the post-operative complications like the delayed gastric impacting. So we performed a study to conclude the feasibility and the effectiveness of the LPPPD. The patient was 42, include 42 patients who underwent the LPD and LPPPD between 2010 and 2014 in our center. The patients were divided into the LPD group and the LPPPD group in terms of the surgical approach. All the people included in our study will meet the inclusion criteria, like the benign lesions of the pulmonary or the pancreatic head, the malignant lesions of the duodenum or the distal bile duct, and the malignant lesions of the pancreatic head without the invasion of the pylorus or the duodenum, and the lymph nodes surrounding the pylorus are negative of the tumors. The differences between LPD and the LPPPD was whether the pylorus is resected and the other surgical procedures are the same. The basic information of the patient between LPD group and LPPPD group was the same, like gender, age. The postoperative pathology result shows that the margins of the specimens were negative of tumors, and the pathology result distribution between the two groups were not different significantly. the intraoperative variables between the RPD group and RPPPD group so that the RPPPD group takes less operation times and have less blood loss. And the tumor size, the transfusion rate in the intraoperative were same. After the operation, the post-operative complications like the pancreatic fistula, biotic, or the DGE, and so on, were the same and has no significant difference. So from the study, we can show that the RPPPD is feasible and effectiveness. It can meet the ridiculous resection of the tumors and have less operation time and have less blood loss. But the complications, the post-operative complications were the same between RPPPD group and the RPD group. But because of the cases we included and the time we follow up, so in the future more cases should be involved and the long-term follow-up should be done to evaluate the effect of the long effect. Okay, thank you.
Thank you, Dr. Zhang. This paper is now open for discussion. I guess I would ask you, in your evaluation of patients, again, it's important who we operate on, and you mentioned the superior mesenteric vein and other vascular involvement from tumors. What imaging studies do you use to make a determination that you should not operate on a patient?
Before the operation, we perform the CT, MRI, or the ERCP to determine whether the vessel was invaded.
Are you using laparoscopy preoperatively?
No.
Questions from the audience?
How again did you decide which operation would be done? Was it one surgeon doing it and another surgeon doing the other, or it was randomized, or how did you decide what? Because all the factors you say the patients were identical, so how did you decide which operation?
The cases we involved in our study were performed by the same surgeon. Not only one surgeon in our hospital performed this surgery.
And so, like for the first 2 years, they did one type, and the second 2 years was a complete switch, or it was just surgeon choice?
Yes.
Okay.
Okay, thank you.
Thank you very much.